and we appreciate you for being with us. We appreciate your steadfastness. We have your toughened stance. We appreciate your toughened stance to be able to make it happen. And I will call on Professor Kudi to introduce you briefly. You all are colleagues, so I don't think Professor Kudi needs any piece to describe you. He can describe you extempo. So, and then you come in and discuss contagious bovine Pleuro pneumonia. So thank you very much, Professor Okayito. And then right on.
Thank you very much, Dr. Charles. I'll begin by introducing Professor Okayito, who I know for a very long time, not only as a colleague, but as a very good friend of mine. And when I say friend, you know what I mean. And we have been interacting. We have been working together when I returned from the UK. And I know his worth. I know his work. Professor Kaito finished his DVM, MSc and PhD at Ahmadu Bello University, Zaria. Okay. And even before he entered DVM, he was a staff of the faculty. And he has been serving in the area of infectious diseases and always going.
Okay. Sound.
Now unmute yourself, sir. Unmute yourself. Where is he?
Yes.
Does it crashed out?
It's network. It's network.
Yeah. They're having network glitches. So just like he's saying, Professor Kaito started as a non-academic staff to academic staff and then to a professor. That's what he's trying to tell us. And then today, he's a professor of infectious diseases. And he will discuss contagious bovine pleuropneumonia. It's a little bit tardy in Zaria right now, but we'll get things sorted out. Unfortunately, we've gone online and I don't know what to do.
Can you hear me? Sorry, I'm back.
Yeah, you're back. Yes, continue.
The next one is so. All I want to say is that we normally call him synonymous to Fulanis because they all know him in northern Nigeria, right from the Middle Belt to the far north. If you talk about the Sahel, we're talking about Maiduguri, Potescum, etc. There's no place Okayito has not gone when you talk about Fulani ambulatory and dealing with infectious diseases of livestock. All I can say is that there's no better person that I know that can tell us about CBPP than Professor Okayito. And I'm glad that, he's here to share with us all these years. He has over 40 years experience in this area, and I'm sure we are going to learn one or two things from him. So, ladies and gentlemen, I present to you Professor Solomon Okayito, who will be talking to us on CBPP. Thank you.
Is it going to use your device? Yes.
He's using my device, sorry.
Okay.
I'm trying to connect him to the other device so that you can see his face.
No, let him come. Let him come to your place. Let him come. Step out for him.
He's talking. No.
Yeah, we are hearing you faintly.
All right.
No, we are not hearing you. Come and use Professor Kudi's device. Let him use Professor Kudi's device. Professor Kudi, unmute yourself. You're a moderator. Unmute yourself.
Yeah, but he has to impute his data or whatever he's using for the presentation to Kudi's system.
Yes, so we can be discussing so that we don't break even. As I was saying about Professor Okayito and I was saying about the program, we were going to our list of resource persons. From
hello? Okay, can you hear me?
Yes, yes.
Hello.
Yes, we can hear you.
Can you hear me?
Yes.
Yes. All right. Thank you very much.
Yes, sir. We can hear you.
All right. Like my friend had introduced my humble self, I am to talk on CBPP. Let me start, with the historical background. The first case of CBPP, was recorded in Nigeria in 1924. And between 1924 and 1960, there have been several outbreaks, about 200, outbreaks on a yearly basis. Okay? Between 1965, CBPP was under control. Between 1965 to almost about 1975, the disease was controlled through vaccination. All right? However, the scenario today in Nigeria is an endemic country for CBPP. In fact, that is what we call endemic stability. Nobody talks about it. Nobody do anything about it. The disease is there, ravaging the livestock industry. All right. So I will look at, how do we recognize the disease in the field? All right. And then what are the things that need to be done? Now, CBPP, is a bacterial disease. All right. It's a bacteria that, does not have a cell wall. It has lost its cell wall through evolutionary trend. So you cannot say it's either gram-positive or gram-negative. All right. So the disease is characterized by three phases. We have the hyperacute, we have the acute, and then we have the subacute or chronic. In the acute, the disease presents itself, with a devastating nature. That is, the animal will show high temperature and just die. No premonitory clinical signs. While in the acute, there are clinical signs that the disease presents itself. For instance, one of the complaints the herdsman or the farmer will give you is that the animal is lagging behind. All right? So when you visit the farm and then you look at these animals, there are some certain clinical signs they exhibit that, sometimes we say they are pathognomonic to CBPP. For instance, the animal, obviously will lag behind during grazing. The animal will be looking for a shade. All right. There will be extension of the neck in the direction of wind. There is abduction of the forelimb. All right. And then protrusion of the tongue, drooling, salivation. Those are the classical signs you see, in CBPP. And then of recent, we realized that even bloat is beginning to, to appear as one of the clinical signs. But I'm sure you will be wondering, how can bloat, a digestive problem, come up as one of the clinical signs in a respiratory problem? I think we'll explain that much later in the course of our discussion. All right, so the disease is there. So those are some of the clinical signs you see, when you are dealing with an acute form of CBPP. And when you do physical examination, you will realize that the mucous membrane, that is the conjunctiva, is severely congested. All right. And then, of course, not to talk about high rectal temperature, a temperature that will range from 40 to about 42 degrees centigrade. All right. And then, of course, when you look at, the respiratory system, it's going to be exaggerated. Sometimes it's even costo-abdominal, because of the lesions, that are affecting the lung tissues. All right. So that is the acute form of CBPP, the clinical signs you observe in the field. Then, of course, the subacute or chronic is the one that is very tricky. If you don't use, your stethoscope to auscultate, you might not be able to know, because at that level, the animal is just shedding the organism in the environment, but not showing any obvious clinical sign. All right? So that is it. Okay, so CBPP, like I say, is very devastating. Okay, and then one of the things that makes it a very, very important disease or economically important disease is the fact that, you cannot treat. Treatment becomes impossible. And I will explain why it is like that. For
Yeah, his glitches is coming in again. His glitches is coming again. We'll be in it before. We'll be in it. There's not much we can do. Okay. There's not much we can do. We will be in it, but as God will have it, we are going to finish it. But next time, this will be a teaching point in our struggle to make this thing, to be on the very nice side of history. He has crashed out. He has crashed out. Somebody should call them to tell them that they have crashed out of the.
I think they will know.
They might not know. They might
Okay.
not know. All right. You have their number. You have
Hello, can you hear me? I'm back.
Yes, you are back. Yes.
Hello.
Yes, continue.
I'm back. Can you hear me?
Yes.
Okay.
Yes.
Like I said, I was trying to describe the clinical signs associated with an acute infection of contagious bovine Pleuro pneumonia, which I have listed. I don't have to repeat myself. Okay. The acute form, the chronic form, does not manifest any serious clinical sign per se, other than the animal, discharging the organisms in the environment. And sometimes the animal will become very unthrifty, and then the client will continue to complain that his animal is not doing well. All right. But I'm more particularly interested in the acute form of the disease, because if you are able to catch it, early enough or catch, the disease at the acute phase, you can treat.
Yeah, he's still having some issues. I'll remove his what do you call it? Yeah.
No, the network will be rolling. So I think let's be patient a little bit.
Yeah, we'll be patient and we'll be talking, and we can understand what he is trying to continue.
All right. Sorry, Okay, sorry for the hiccup. Like I said, I'm particularly interested. I want people to realize that much as, we said CBPP is not treatable. It depends at what stage you are able to, pick the infection. If you get the infection at an acute stage, yes, you can treat. Let me explain. Probably I will delve into the pathogenesis of the disease. Now, once, in an acute stage, once the animal pick up the infection, we know that, the mycoplasma organism will be deposited in the lungs. You can do endotracheal. In fact, you can do experimental infection if you so desire. But then in the field, once the organism is deposited in the lung, it's established itself. And I used to tell my students, that CBPP or Mycoplasma mycoides or species mycoides is a very clever, mycoplasma organism. It has a survival strategist. Okay, once it's established in the lungs, it secretes on certain chemical substances. We call that a galactan. That galactan is a polysaccharide. Okay, what it does is to destroy the tissue, the lung tissue, where it is, the foci that it lodged. It's a kind of protective mechanism. Destroy all the tissue, destroy the microcapillaries so that blood supply to the area, will be hindered. So once you catch this infection, at the level that this polysaccharide has not been secreted, yes, you can treat. And how do you know it clinically? You can know that clinically when you can auscultate all the lungs and pick, the respiratory sound. Now you'll be wondering, how do you, do that? Like I used to teach my students, we have 7 lobes, in the thoracic cage of an animal. You have the apical, you have the diaphragmatic, you have the cardiac, and
it's gone out again. I hope we are getting everything he's talking about.
Yes, sir, we're getting it.
Yes, that the disease is endemic. And being that it's endemic, there's no concerted effort. There's no concerted effort for a national drive. For a national, there's no concerted effort for a national drive for its control. And from control to eradication. You don't eradicate before control. You start controlling before you get to eradication stage. Yes. Yes.
All right. I'm back.
Yeah, you're back. Yes.
Can you hear me?
Yes.
Hello, Charles.
Yes, you're talking about the polysaccharides. Yes.
We can now hear you, sir.
Okay, yes. The polysaccharide, like I said, it's a galactan, that's the mechanism, the organism, produce, it enhances survivability wherever it found itself. Destroy the tissue around, reduce the blood supply by causing the blood vessels, to constrict, so that even when you try with antibiotic, you may achieve a high plasma level, but very little will get to where the organism is, located. And when you post that animal, it is, this polysaccharide, this necrotized tissue that form what we call the marble stone appearance. So before the formation of the marble stone or, the capsule, if we may use that word, you can treat. When you use tylosin, you use oxytetracycline, you will be able to, destroy, the mycoplasma organism. But then you must have a good skill of auscultation. You must be able to auscultate, all the lungs, all the lobes of the lungs. But then let me add here quickly that,
Yeah, he's talking about the treatment, what do you call it? Tylosin has been terribly abused, honestly, terribly, in the treatment of CBPP, and it's causing a lot of hiccups. Even in the treatment of chronic respiratory disease in poultry.
Hello, okay, yeah. I'm using his phone.
Yeah, continue.
All right, so like I said, if you are able to auscultate and pick out functional lungs, either the diaphragmatic or the apical or the cardiac, and then of course you cannot pick the mediastinal lobe because it's down there around the xiphoid cartilage. Then you can be sure that when you introduce your antibiotic, it can get to where the mycoplasma organism is in the lungs. But once, this capsular formation forms, and then it moves to chronic infection, even if you treat, you may achieve a high plasma level of antibiotic, but nothing gets to where the organism is located. So, and that is where, the animal assume a new status of a carrier. All right. So that is it. So, but then, that's about, how CBPP does and ravage through, the respiratory system of, animal. But then how do we control the disease? The control of the disease is essentially through vaccination, But then I realized that most of our people, when I mean our people, I mean our graduate students, vaccination becomes a problem. Why? We may teach them, we do teach them exactly what to do, but then sometimes when they finish, they start doing things their own way. Let me give you one scenario, Charles. I was in Zamfara State. Sorry, I don't want to mention state. I was in one of the states, not Zamfara. And they mounted a vaccination campaign. I now visited them in the point they are doing the vaccination. And I realized I saw some cartons of fluid. And when I looked closer, I realized that, they were using 5% dextrose in normal saline as their diluent for vaccine. And I asked the doctor there, he's my former student, I said, what are you doing? He said, well, they are having vaccination campaign, so he's using 5% dextrose as a diluent. I said, no, if you do that, you are not going to achieve anything. In fact, by the time you suspend the mycoplasma, in your diluent, you will succeed in even killing them because they will rupture. So remember that we have certain amount of, mycoplasma organisms in a vial of CBPP vaccine. We have up to about 10 raised to power 7 coliforming unit. All right. So, you can imagine a state like that, using dextrose saline, to do a mass vaccination. At the end of the day, nothing will be achieved. And like I told him, I said, that explains why, the disease is still with us because we keep doing the wrong thing in the field. All right. Now, apart even from the diluent use, a number of them, for ease of administration of the vaccine, they dilute the vaccines with 100 mils of, whatever diluent they choose to use. And I said it's wrong. Because if you follow specific instruction of MVRI, what they said, the label on the vaccine, on the bottle of the vaccine, is that you use 50 ml of normal saline. Okay, so why do you have to, increase it to 100 ml? If you increase it to 100 ml and then you are over diluting, how many coliform units are you going to, administer that will be, that will trigger the immune system? So those are one of the factors, that you realize that is creating a big problem, for us, in the field. And again, when MVRI liberalized, the sales of vaccine, it created another. Yes. Hello?
Continue. Yeah, we're hearing you.
Oh, okay. I said when MVRI liberalized the sales of vaccine, an ugly scenario, emerged. Clients began to go to MVRI to get vaccine, CBPP vaccine. Let me give you one scenario. A client came to me, that was a few years back, and told me that his animals are dying of CBPP. He came from Katsina State. I took some students, we went there only to discover that this man has about 120 animals in his herd. He went to MVRI, bought 20 vials of CBPP vaccine, came back to his farm, emptied all the vials, inside a swan water bottle, and he was giving them 5 meals. Now, what do you think will happen other than the animals will come down with full-blown CBPP disease infection? So that is one of the scenarios. And I asked him, why did he, use that kind of, why does he have to buy so much? He said, well, his animals are showing signs of CBPP. He's getting so frustrated. I said, but you know where we are. Why didn't you come? He said, well, somebody told him that he can do it himself. But then at the end of the day, this man lost all his animals. Okay? And honestly, we need to do a lot of sensitization, with our farmers. CBPP is a notable disease. CBPP is a disease that is well known by every farmer. And they thought that it's a disease that can be managed using antibiotics. So they do it indiscriminately. And that explains the reason why, the disease is endemic. And then we have live with the disease syndrome in Nigeria. I don't know how we are going to control it. But then if we are, in fact, we must. Some few years back, 2020, Federal Livestock Department and Pest Control Services came up with, a plan to control CBPP in Nigeria. All of us were invited to Abuja. We sat down, we drew up, a policy plan, a plan of action on how to control this disease. Okay? And I understand it was a World Bank project. I don't know how much money is involved. But then we spent nights, to come out with a plan of action. We did everything. I was so excited. I said, for once, we're doing something good. At the end of the day, this is about 5 years now since we drew that plan. All the plans were distributed to state, veterinary services, and we even have, a copy here in the veterinary teaching hospital. That was the end of, the project. They call it LPRES. LPRES was supposed to handle CBPP also. So nothing is being done. Okay, so as I'm talking to you now, CBP is endemic, it's here with us, and we have to live with it. I'm so happy when I heard that the Ministry of Livestock Development is coming on board. And I was thinking, I said, okay, with this, I think maybe a plan of action will be put in place in how to control some of these, diseases. Otherwise, our livestock industry will continue to be in a mess. Now, for the past 4-5 years now, we are unable to go out, to see clients because of the insecurity. You can't venture out. If you go out, you will not come back, you'll be kidnapped. So the Fulanis are actually on their own. I don't know what is happening with the private veterinary clinics or practitioners. I don't know whether they're able to go out. But then, the nomads or the farmers, they are on their own, So that is it. So I don't know, maybe if there are people that will ask questions, it will stimulate more discussion. Thank you.
Yeah, Prof, you just nailed it, honestly. Professor Kudi, you take over and see how far we'll go. And those of us who have questions, please put it on the chat box. Let's see how far we'll go. Yeah, put it on the chat box, please. Anybody that has
questions. Thank you very much. I think we've all heard him. And as he rightly says, CBPP is one of the most important transboundary diseases that we have today. And I think because of the effect of climate change, it's also contributing to the high incidences we are seeing around us, in addition to all the lapses around vaccination, etc. Just to add a little bit to what he has said regarding the problem of the disease, I happen to just do some survey of CBPP organisms from clinical cases. And what we discovered is that we have realized that the organism have started mutating. And because it has started mutating, there is this big question of whether the vaccine produced in MVRI can actually protect or, initiate protection or not. And because of that, I think I had word with MVRI and I gave them the result of the study, because we got about 5 different mutated species of Mycoplasma mycoides small colony. So that adds to actually the problem that we're facing in the field. These are practical problems. You can get the vaccines, you can go to the field, you can vaccinate correctly, but the organisms are mutated, there is the possibility that there will be no seroconversion. And if there is no seroconversion, it means it is a wasted effort. So really we have a large task before us to be able to deal with this disease in our livestock. That being said, I think now is for us to actually ask any question we might have or any contribution from anybody that might have. Although Charles said that you should write in the chat box, I'll be checking the chat box to see some of the questions, but if there's anybody, you can raise up your hand and then we can give you
Lawani has just asked one question.
Okay.
Yeah. Lawani.
Okay, let me see. Okay.
Lawani just
Yes, I'm seeing it now. What of the pathogenesis of bloating what is the public health significance of CBPP? That's what Lawani is asking.
Yeah.
Do we give him to address it?
Yes. Then while others
thank
prepare
you very much. You know, of recent, like I said, we start experiencing bloat as one of the presenting clinical signs, though not in every animal, you know, that is infected with CBPP. I don't know why. But then you realize that, you know, essentially CBPP is an inflammatory, you know, condition, you know. One of the pathologies it causes, you know, in the thoracic cage is pleuritis. That is inflammation of the pleural membrane that, you know, cover the lungs. In some very bad cases of CBPP, you will see adhesion of the pleural membrane to the thoracic cage. Now, the trunk of nerve, you know, which one of the branches innervate, you know, the rumen, you know, of course, the nerve that innervates the rumen is the vagus nerve. It traverses through a meatus, an opening in the thoracic cage. Once there is pleurisy, it affects the nerve. And once the nerve is affected, it causes desensitization of the vagus nerve. The vagus nerve innervates the rumen. And once there is desensitization, there will be ruminal atony, cessation of rumination. And once there is cessation of rumination, there will be ruminal stasis. And then, of course, the microflora will continue to produce, you know, what they know how to produce best, that is the gases. So you will see bloat. I've had a similar experience, you know, when I was a young vet. You know, a client came in, you know, and he complained that his animal is bloating. It's a heifer, you know, about 2.5 years, a female heifer. We got to the farm with some students, and I look at it, you know, I didn't auscultate, you know, as a fresh graduate now, you know, you have so many things. I was very happy thinking that I have, you know, gotten a surgical case, you know, because one of the things that came into my mind is that probably there is, you know, foreign body gastritis in the rumen, you know, that is causing bloat. So I need to open the rumen to check and see what I can find in there. So I, you know, convinced the client that I think we need to open this animal. It is possible that, you know, there are some foreign bodies there. So we opened the animal.
He's still crashed out. Bernard Wabez is asking Sunday, is asking a question for him to throw more light on what he said about current difficulty in going to treat animal. It's because of banditry. It's because of banditry. It's only a tree that you know that you cut it down or you kill it and he will stand waiting for you. Human beings, and like any other animal, will run away. People don't have access to bush anymore to treat animals because they don't want to be kidnapped. So that's why he said it's very difficult going into the bush to treat this animal. And if you don't go into the bush to treat this animal, a lot of things are happening. And more especially when you have a tricky disease like contagious bovine Pleuro pneumonia. I think that's what he's saying. We in the poultry sector, we see mycoplasmosis in chicken, very, very difficult to handle. When in any species they find themselves, in any strain they find themselves, they're very, very difficult to handle. I think that is what he is trying to say. Yeah. So if he comes back again, he will take on some questions. I think I've done justice to this one. They don't go on ambulatory again. The other time I was in Ahmadu Bello University, I heard that a vet was kidnapped in the bush.
Hello?
Continue.
Hello?
Yes,
continue, sir.
Okay, I was sharing a clinical experience. I don't know at which point, you know, the thing muted. You know, but I was trying to, I tried to explain, you know, the pathogenesis of bloat in CBPP. Yes. I don't know whether you caught that.
Yeah, we'll cut it. You're going beyond the ruminal atony.
Okay.
Because of dysfunction of vagal nerve.
The vagal nerve, okay?
Yes.
All right. So that is it. So when I realized there was nothing inside, I closed the animal up. The following day, the animal died. So we have to post it. I posted the animal. I realized that it was a classical, CBPP condition. All right. So for the fellow that asked question on how does the bloat comes about, and I think that explains it, is desensitization of the vagus nerve that innervate the rumen. All right. Hello?
Yeah, continue. Yes, continue.
Yes, continue.
Hello?
Yeah, continue.
Continue, sir.
God, we're hearing you.
They can hear you.
Yeah, we're hearing you.
Can you
yeah,
hear
we're
me?
hearing you.
We can hear you, sir. Go ahead.
Okay,
Right.
I said that explains why, you experience or we experience bloat, in CBPP condition. It's not a regular, occurrence, but it does happen from time to time. And I want listeners, clinicians like me to have it behind their mind that when they see bloat, let them not think, that they are dealing with, foreign body gastritis, or some rumen-related problem. They should also have CBPP as one of their differentials. And I think, they should try as much as possible to rely on auscultation. The good thing about CBPP, you don't find the two sides of the lungs, infected. Only one side, sometimes either the right or the left. And among the three lobes, mostly about 90 to 95%, you find the diaphragmatic lobe infected. Okay, so we can concentrate, try as much as possible to see how, you can auscultate the diaphragmatic lobe. If you cannot pick any sound, meaning that, the lung has been consolidated, that is consolidation of the lung. In other words, most of the lung parenchyma, has been taken over, by this fibrous connective tissue, in the formation of the capsules we talk about. All right. Okay. So have I made myself clear?
Yeah, you made your statement. Prof.
Yes.
I have not been in bovine practice, for quite of recent because I moved into canine and poultry and then moved to poultry. But when we're dealing with CBPP, when we're in school, we do everything humanly possible to remember and recall some statements. And what we used to think about CBP is a breakfast. You remember breakfast, we always remember our breakfast mood, like bread and butter appearance of the lung, like the egg yolk colonies, egg yolk colonies of the.
It's not egg yolk. It's fried egg appearance.
Right.
Fried egg, yes. Fried egg appearance.
Fried egg, yeah.
Yes, fried egg appearance of the colonies, and then bread and butter appearance of the lung. What? Throw more light on this.
Yes.
Yes.
Oh, okay. Well, I don't know what really you want me to say, concerning the bread and butter appearance. It's just that, the organism itself, like I said much earlier on, it developed a strategy, for self-sustenance, once it enters into its definitive host. What it does, like I said much earlier on, a chemical substance, the polysaccharide, is the one that destroyed the lung parenchyma. It destroyed it, made it in such a way that, in fact, it necrotized it. Okay? And all these things, like I said, is a survival instinct, for the mycoplasma organism. It tends to protect itself. Okay? And like I said, once that happens, even if you give antibiotic, nothing goes in there. Because the microcapillaries that supply that part of the lungs, with blood, is completely destroyed. So you cannot achieve, even if you achieve a sustained plasma level, very little can get to where this organism is located. So the organism enjoys itself, it remains there, and then continue to drive. When there is adverse environmental condition, where there is stress, of, let me use the word trekking, up and down in search of fodder, that capsule breaks. And once it breaks, the animal will begin to shed, this organism in the environment. And of course, animal within 100 meters, susceptible animal can pick the infection. So that is it. So I don't know whether it explains, it answers your question on bread and butter.
Lumens Chukwu is asking that he has seen some Fulani herdsmen managing CBP case with Tylosin but injecting through the intercostal region. What is your take?
No, you see, the thing is that, like I said, if you catch the infection at the second phase, that is in an acute form, yes, you will get some, some kind of relief. In fact, the animal might even recover. The animal might even recover, but then once it goes to chronicity, my brother, don't waste your time. You may have some, palliative, some reliefs in the manifestation of the clinical signs, but the animal cannot recover 100%. It cannot.
Can you use antibiotics to maintain the serum level, to reduce the serum level? Because it is only when they get into the serum, the blood system, that's when they'll start to trigger a lot of things. Do you still, do you try to restrict and constrict them there by using antibiotics?
Yeah, but then how many, see, look, I shy away, from asking nomads, to use antibiotics to control CBPP, because number one, they can never estimate the weight of the animal correctly. Okay? So if he's supposed to give 25 mil, let's assume he's to use a long-acting, 1 mil per 10 kg, and the animal weighs about 250 kg. You and I, we can estimate the weight. We can give the correct dose. But for the Fulani man, he bought 100 ml bottle. Can he afford to take 25 mil and jab while he has maybe about 10 animals to treat? So that is one of the problems, They can never correctly estimate the weight of an animal. They're not trained for that. It's not their work. All right, so that is it. So if you are advocating that, let them use, my take on this.
No. Hello. You are getting me wrong. Not for self-treatment. No, yes. I don't advocate them. They don't know what they're doing. It's quackery.
Exactly.
Yes. It's quackery. I'm talking about veterinarians who consult them if they are consulted. We're dealing with a normal situation, not the abnormal situations we see ourselves.
Yeah.
Do you advise vets to treat their animal by shutting down the level of the microorganisms in the lung, restricting them in the lung, so that they don't trigger, they don't come out, so that anyone that comes out is gone?
No, I don't advocate that, but that is the way we can go about it. You can actually use antibiotic, either long-acting, in conjunction with a steroid. You put the steroid there in order to enhance, the integrity of the blood vessel, so that is going to be more tissue perfusion, so that your antibiotic can get at least close to the site of, where you want it, to go. But my position in that, I will advise that if truly you want to introduce the usage of antibiotics in the management of contagious bovine pneumonia, that's the way we can do it. One time I wrote a submission to TED Fund, so that we can try our new generation antibiotic. The ad was saying the ciprofloxacin, but they didn't consider it. You can actually go in and treat all the animals with antibiotic, either tylosin or long-acting. Then 2 weeks after your treatment, with the agreement of the client or the farmer, you can go and get vaccine. This T144 vaccine, enter the heart and vaccinate all of them. Now, when you do that, the animals that respond to the treatment of the antibiotic, meaning that the mycoplasma organism has been knocked off, will not react to the vaccines you administer. But those ones that refuse to recover or to allow the antibiotic to have effect on them, meaning that they are still carrying the mycoplasma organism, they will come down with full-blown clinical sign that they have to be separated. So you can do that, but then the client has to be informed, he has to agree, so that's another way of, antibiotic intervention. You can do that, But then, like my friend here said, you have to look at the cost-benefit analysis, because, of course, antibiotics, are very expensive, And then what do you do if, say, probably about 20% of the animal didn't recover, they are showing full-blown clinical signs? Of course, you have to remove them from the herd, okay? But then you can encourage the client to sell them and then buy clean animals and replace them in the herd. And then you will have a clean herd. I have done it in some farms, you know, in agreement with the farmers, you know, that is, we go in, we treat, and then 2 weeks after, you know, we vaccinate. And then another 2-3 weeks, we go back and examine all the herd to see which ones recover, which ones are still, you know, or rather have come down with full-blown clinical disease. So that is it.
Yeah. Professor Kudi mentioned something, and he spoke. Let me just you know, as a comment, he spoke about many strengths, many antigenic strengths of CBPP mycoplasma.
Yeah.
But you see, what I'm trying to say, in a country like us, where antibiotics are abused, many strengths, new strengths are bound to be copies, many strengths and copies of organisms are bound to be generated. Because when you give these drugs at sub-therapeutic level, you are awakening the consciousness of the organisms to mutate. And when they are mutating,
yes.
When they are mutating,
Charles, sorry, let me cut you here.
Okay,
let
good.
Me understand. We have agreed that it is the veterinarians that do the treatment. Veterinarians cannot give underdose subtherapeutic regimen. We are talking about scenarios whereby, you know, if the animal weighs about 300 kg and you are using long acting, you are supposed to give 30 mil. If you give
no. Let me say where my mindset is heading. My mindset is heading where the quacks. Right now, we have moved from where veterinarians are in control to where quacks are in control.
Yeah.
I'm trying to make up the point, fix up the point. Professor Kudi is saying that a lot of variations, strain variations are emerging in the field. I'm just trying to discuss the roadmap. Because of antibiotic abuse, microorganism abuse, antimicrobial abuse. And if a study of MR now, antimicrobial resistance, which is part of this mutation we're talking about, it is heightening, by the day. So now they are resisting, they are changing their genetic configuration to resist, because they're not fools, to resist those chemicals, those drugs. And in that process, when you give them those drugs, they will not respond to it. They will be very resilient to it.
No,
I'm moving to genetic copy to vaccination, the antigenicity. And then in that mode, they can mold themselves that they didn't even respond to the antibodies. Before then, you know it, they won't respond to the vaccines. Okay, continue, sir.
No, I want to disabuse your mind. I'm not sure, you know, the different variant we have in the field is as a result of usage of antibiotics.
Okay.
No, I have a PhD student, you know, he did his work in the southeastern part of Nigeria.
Okay.
Okay. He looked at CBPP in about 4 senatorial districts in the east. All right. And he discovered that there are about 4 different variants, okay, of CBPP, of mycoplasma, where he compared with the vaccinal strain. Okay. So I think mutation does occur, you know, over a long period of time. Look at how long has CBPP been in Nigeria. The first documented case was about, let me use about 90 years ago, from 1924 till date to 2024. That's about 90 years. Okay, so you think, you know, bacteria or organisms will remain static? Look at FMD now. FMD were having several serotypes out there in the field. So mutation due to environmental changes, climate changes, do occur. Usually the organisms, will have to devise a means of, surviving, So I don't think it has anything to do with, either multiple drug resistance or antibiotic suboptimal dosage,
Okay. Okay. Abose is raising his hand. Have you dropped down your hand? Abose, you can unmute yourself and add up.
What are you saying?
No, Dr. Abose is raising up his hand.
Okay.
Before we go to Emmanuel Elisha, what he's saying.
All right.
Dr. Abose is raising his hand.
Yes, sir. No, there was a question from Dr. Ben Akube, who was asking how can one differentiate CBP disease from other respiratory diseases, and are there any available on-field test kit that one can use on farm? That is his question. I don't know whether that question has been answered.
Okay, you want me to attempt to answer the question?
Yes, sir. Yes, sir.
Okay. Well,
we seem to jump the
what are the
question.
diseases that you can easily confuse with CBPP? That is, what are the differential diagnoses? Number one, top in the leaf is pneumonic pasteurellosis. Okay. Now, in pneumonic pasteurellosis, the similarities is so close. The only difference is, is that in pneumonic pasteurellosis, it does not affect a particular side of the lungs, alone. Pneumonic pasteurellosis affects all the two sides of the lungs. And of course, in pneumonic pasteurellosis, there is always stress associated, with the disease. That is why it is called shipping fever or transport fever. Okay, so that is it. So you can do that. And then, of course, in tuberculosis, which, is one of the differentials, and if you look at, tuberculosis, it's a chronic disease, of livestock. And then it causes severe emaciation. And then, of course, the nature of the coughing is not similar with that of CBPP. In tuberculosis, you find the animal, doing very dry cough, emaciating. You look at the lymph nodes, the highly exaggerated and large, and so on and so forth, So, but CBPP is usually unique, very, very unique. Like I keep saying, when you see it, you can't miss it, So because the clinical signs, are usually, very unique. It is the only disease that you can find the animal, extending the neck, abduction of the forelimb, with drooling, salivation, protrusion of the tongue, So there is no any other disease that presents such kind of a clinical sign. So missing it, is difficult, except of course, if we are not versatile in clinical practice.
Yeah, thank you. Okayito, do
Okay,
we have
Prof,
more
he
comments?
He also asked, Prof, whether there are test kits to be used on farm.
Yeah, test kits for now.
Okay, yeah. Around 1999, there was one Ailing, he came out with, a bedside diagnosis of CBPP. We call it lateral flow. But then, it has its own drawback. We realized that, I have even published a paper on that. We realized that it can pick, the acute form of the disease, but it cannot pick the chronic form of the disease. So that is a drawback. Otherwise, within 2-3 minutes, it use whole blood or serum, you can make a bedside diagnosis and know whether the animal is having CBPP or not. Then you can go ahead and, But I think Professor Caleb, my friend, will be able to throw more light on that lateral flow.
Yeah.
If
Professor Caleb.
It's not in the market now.
Yes.
Yeah.
Okay.
Professor Caleb, sorry, sir.
Yes.
Prof, do you have anything to say about that?
Well, the only thing I would say, when it came to the market, it was promising, and we started using it, but the specificity has some questions to it, even the sensitivity with time. And we realized that it's not really a very good absolute diagnostic method that we can easily use to solve our problems.
Okay.
And actually, we have stopped using it. We have gone back to our clinical science or culture at the moment.
Okay.
Yes.
But we
That's
tried it.
clinical pathology. Yeah. Okay.
Yes.
Yeah. Thank you. Somebody, Dr.
Okay.
Felix
Any
Lawani.
other questions?
Yeah, Felix Lawani is saying, what of the public health significance effect on reproduction at the 3 stages of the disease? Does it have any public health implication?
Any public health?
Yeah,
well, we really thank God that CBPP is not zoonotic.
So we can eat the lungs now.
You can eat the lung, but then you can condemn the affected part. Like I said, only one portion of the lung, that is affected. That affected part can, you can trim it, throw it away, and then the other side of the lung is okay. It can be eaten, So that is it. It does not. The only area probably it can affect, the well-being of the animal is that sometimes when at the initial set of the infection, the fever might be so high, so high that if animal is pregnant, maybe 2nd or 3rd stage of trimester, she might be able to throw out the fetus, because, at 42 degrees centigrade, the fetus might find it very uncomfortable to remain, in the uterus. So it might initiate an abortion, So that is it. Otherwise, in human beings, well, nothing that much. It's not zoonotic. If it was zoonotic, probably the government might have taken decision on it by now. People would have started running helter-skelter, find a way of how to, stamp it out.
Even tuberculosis that is zoonotic, how far have we gone in educating them?
The issue of tuberculosis is simply because it affected very few people, Well, and I'm not talking about M tuberculosis, but I'm talking about like M. Bovine, which causes multiple drug resistance, or they call it multiple drug resistant tuberculosis, So it's people that take the risk of drinking unfermented milk, directly from the animal, But I think even the attitude of the farmers themselves is not helping much. I ran into a farm, one time, when Nigeria is at peace, no insurgency, no insecurity. The man runs a dairy farm, and he invited me to come and screen his animals against tuberculosis. I've done that. I did that, and then I realized that a few of them showed sign of they were positive. So when I called his attention, I said, Alaji, these animals need to be called. He looked at me in the face and said, because of what? I said, they are having, tuberculosis. He said, I can't remove it. This animal is giving me 35 liters of milk every day. I said, but what about the tuberculosis issue? He said, don't worry about that. That there was a thought that will survive. And honestly, he did nothing. So that is it. So the even attitude of our farmers, is another issue, So that is it. But honestly, I'm so worried about CBPP, so worried. So worried because, the disease is endemic, and it's ravaging through the livestock industry, and nobody is doing anything.
Do you think the spread of the disease, because of the movement of the cattle rearers from one place to the other, mixing up to vacate and mix up again?
No, actually,
does it has
yes, actually the form
implication?
Okay, I'm listening.
No, what I'm saying is that these herders, they mix their animal where they're drinking, where they're grazing. Does it have any effect in? Are you hearing me?
Prof, we can hear you.
Prof, Okayito, we are hearing you. Yeah. He was talking about.
I think he just went.
Clara Akpan is raising her hand. We will allow her to speak, and
Okay.
and then allow when Okayito comes in, Professor Okayito comes in, and then he will address some of the issues. The issues he's talking is like there are a lot of issues which we all know, the fundamentals in this country. So we don't want to dwell into it, because if we dwell into it, we cannot go today. If he comes back, he will trash some issues. Hassan Akpan will talk. The Dr. Akpan.
Prof is back.
So, Prof, but I was anytime there's an interlude, anytime there's a glitch, we'll fill it up. Oh,
okay.
Well, anytime we'll by discussing his paper or something like that. Okay, Prof, you're back. Yes.
Yes. So that is it. So, like I said, we need to wake up, as a profession and see how we can stamp this, CVPP out of, animals. It's possible we can do it if we have the will, the political will to do it.
Yeah. The question I'm asking you, I was asking you, the mix-up of these herders with their animal, but maybe where they go to graze.
No, it is. It's one of the factors. There is nothing you can do about it. Okay. Absolutely nothing. Because the issue is that, whether you like it, transhuman activity of the nomad, we can't stop it. They have to go out, from morning till evening, searching for green pastures. You said?
Yeah.
Hello?
Yeah, we are hearing you.
Hello?
Yeah, we are hearing you. No, we are hearing you, sir.
Oh, okay. Okay. Hello, are you with me?
Yes.
We are with you, Prof.
Oh, okay. So, like I said, I talk.
No, talk.
Prof, we can hear you.
Prof, we can hear you.
Okay. Okay. Like I said, the transhuman activities of our nomad, our farmers, there isn't anything we can do about it. Because they go out in search of green pastures, they cross states, they cross barriers, for the sake of the animals. So once you have.
Yeah, he's confirming actually that that mixing of animal has a way of spreading the disease. Yeah, spreading the disease.
All right.
Yeah.
So that is it, Hello, are you with me?
Yes.
We are with you, Prof.
Oh, okay. So like I said, the nature of animal rearing in the country, informed, the spread of the disease unhindered. What we would have should have capitalized on is adequate vaccination. In the good olden days when we started practice, way back in the 1990s, around August, September, October, November, that is the period states launch their annual vaccination campaign. So you realize that most of the farmers that are planning to go on what we call dry season grazing, they will gather their animals, they will request for for vaccination, and they'll be vaccinated. And once they are vaccinated, then of course, they are covered. And then one other thing again, is that, NVRI should be encouraged to go out to the field to check, the different, variants of CBPP, microorganisms that are out there, so that they can remodel their vaccines. Because T144, is outdated. This is a vaccine that, was produced way back 1980. And 80 to date, a lot of water has passed under the bridge, So that is it.
Now,
so if really
3 weeks ago, we were with the ED of NVRI.
Yes.
And we spoke a lot about repository of the data, having a repository or a data bank of all the strains and varieties of strains of antigens we have in the country.
Yes.
So that you can use it to mold your vaccines.
Exactly.
So that you will not be behind the line. We spoke a lot about it. But you know, they will just tell you funding. Because diseases like fowl cholera, sorry, I'm in the poultry sector.
No, it's okay. It's all right.
Diseases like fowl cholera has over 5 strains. Oh. And people are bringing a lot of vaccines into the country.
Vaccine.
Are they doing the right thing? And then the fowl cholera is on the scourge. So we should do the right thing. We're in the digital era. Yes. You know, if we have a data bank, and then you produce, like you said, you saw 4 different strains. We can have a data bank and then update them, you know, maybe periodically. If you have 8 strains, you can merge them and produce diseases, produce vaccines. With them.
Yeah.
But you see, that's okay. But do you think that you spoke about the capsules where they hide? Hello. Do you think the capsules where they hide? Do you think that the stress of traveling and trekking from one place to the other breaks those capsules?
That is exactly what breaks the capsule.
Okay.
The stress of trekking and then, of course, malnutrition.
Okay.
Those are the factors, you know, which, you know, we can't shy away from. Maybe when the ranching issue comes up, you know, that's a different ballgame entirely. You know, then, of course, you know, the picture might change a little bit, you know. But for the time being, you know, you see them moving up and down. And of course, now with the insecurity that is everywhere, they have moved deeper into the.
Yeah. So, Clara, let me unmute. Clara? Hello? Unmute yourself.
Yes, sir. Yes, sir.
Unmute yourself and then raise your.
Yes. Okay. Thanks for this opportunity, sir. Thanks for the insights we've gotten so far. Okay. No, I want to.
But let me ask you, you're lecturing in which department?
Veterinary medicine.
Veterinary medicine.
Medicine
do you attend
department.
Conferences? Okay, do you attend conferences?
Not all the time, sir.
What makes it not all the time?
I'll try my best, sir, to be attending regularly.
Okay, do you enjoy topics like this?
I do, sir, very, very well.
Do you know what it shows you? That you can't get it all within the walls of the campus.
It's true, sir.
You need to break out to reach out. And we've been on this advocacy of breaking the walls. Are you hearing me? Breaking the walls.
Yes, sir. Yes,
you can't break walls by remaining in situ. And we discuss a lot and we say a lot that you can't be an indoor person and get an outdoor blessing.
It's true, sir. It's true.
Once you reach out, you are in veterinary medicine. Are you part of any international organization in veterinary medicine?
No,
that periodically have summit?
No, sir.
Why? Because if you belong to such summit and you present a very good abstract, they can invite you to come and even paper poster presentation. They can invite you to come there, and then you might be able to interact with other researchers all over the world, aggregate yourself into research colonies. Funds are flying all over the places.
Okay.
No, and that's how people get into. I think by the time we finish, we will bring Professor Fashina, because this discussion we're having on this platform is on all embracing. It is not limited, so that we can, and part of it is breaking the walls. Fashina, last week, were you here last week when Professor Fashina spoke?
No, sir.
Were you here? You were not. Anyway,
no, sir, I wasn't.
Okay. I don't know why, but Fashina will maybe address some of, just to give a pep talk on it. He gave a pep talk last week. Our idea of congealing ourselves in this space is for us to break the walls. There are a lot of walls, be it psychological, be it financial. I don't think somebody is into research and doing a lot of research and the person will be poor. That means you can see the financial wall broken, the psychological wall, information wall. That's what we're trying to do, to break those walls as part of corporate social responsibility. Many people don't attend this. We don't care. We will continue to flood here with discussions like this. And then, because if you are not informed, you are de-informed. Anyway, whatever be, okay, continue, sister. Sorry, we're just trying to use it to
no, sir, I really appreciate the advice and the encouragement you've given me, because it's something that will help one in one's career. So I really appreciate it. Yeah. You don't need to tell me sorry. It's for my own good. Yeah. So the input I want to make has to do with treatment. You know, we've heard that the treatment of CBPP is somehow difficult if it passes the acute stage. So I was thinking if maybe a research, I'm thinking of how we can bring in MSAMs, that medicinal synthetic aluminum magnesium silicate, the one Prof. Zibe produces, since it helps drugs to, you know, to be assessed in sanctuary cells. That means tissues or cells where ordinarily the drugs won't be able to get to, being a nanoparticle. If there's a way it can be incorporated in this treatment, I think there could be a breakthrough in that way. That's just
we are fortunately our speakers today, both the moderator and the speaker, are in the research world. All they do is to call, because to call for those products, for them to try it out in their research world.
Yes.
And then they'll
Charles, can I come in? Yeah.
Yeah, come in, sir.
Yes.
Hello, can I come in?
Yeah,
Prof, we can hear you.
Yeah, one of the consequences of using nanoparticles is their effect, residual effects. And even those that have been using it is really not kosher at the moment. And we need to exercise caution when you're using nanoparticles, because most of them actually remain in the cells, and you don't want that, even though they will help you deliver to the target organs that you are interested in, but they remain there. And up till now, we're trying to find out what are the effects of them being retained, you know, in the system. So yes, it's a good technology, but it has a lot of unanswered questions. We don't want to compound our problems.
No, but the research can answer those questions.
No, we are doing research. We are doing research on nanoparticles.
You see,
and these are some of the effects we are getting at the moment. I'm just trying to shed some light. It's a good thing, but we have to take it with caution. That's just what I'm saying.
That's the public health implication. The public health implication of it.
The public health implication. And so also to add about...
These are things, papers. We need to get these papers.
Don't worry, you'll get it.
Yes, we need to get these papers. And then, you know, the nanoparticles, in fact, the nanoparticle, from my understanding, was originally used to see whether they can kill cancer cells. Now it's moving into areas of interest.
Yes.
And we should flow with that area of interest. If there is any side effect, let us know the side effect. Let us know whether it is an avoidable side effect. If it's an avoidable side effect,
that is what.
Yes. So we want
to. That's what it is still being monitored.
Up till tomorrow.
No, don't worry. You will get them when we are still alive.
Yes, up till tomorrow.
Because right now I'm working on nanoparticles on how we can see whether they will transport some key medicinal plants, you know, in fish. And part of it is to look at the residual effect and the consequences. So possibly we'll have an answer for you very soon.
Because up till tomorrow, oxytetracycline was discovered in 1950-51 or thereabout. But up till tomorrow, there are a lot of research are being done on oxytetracycline.
Still, I know.
So research is not stagnant. It's not stagnant. It's not fixated.
No, it's dynamic.
It's dynamic. So, but the important thing is that there is, you see, one thing I don't, you know, when this issue about Ezibe came up, just like me, Prof. I remember when I brought Picralima nitida I used it in my final year project to treat trypanosomiasis. And this is a product used in my village, a tree, to treat malaria, proven. But I want to try it on another organism, and it worked. And it's a lot of questions, a lot of, you have not even picked up the material to work on it. I have a lot of resentments, but today, if you Google Picralima nitida, you see my name all over the places. And you see people who have tried it all over the world. Up till now, you put in research. I have up to 111 research reference in peer-reviewed journals about Picralima nitida, confirming what I did, and even extracting the anti-trypanosomicidal agent. So when products come up like this, don't throw it, baby, away with the bathwater. Bring it home. If it is working, it is working. You see, one thing I like to research is the objectivity attached to research is inestimable. If it is working, another person tries it, he will tell it's not working and gives you a reason why it's not working. I don't say, how can this village drug, herb, or whatever, concussion treat trips? No, that is not it. Or how can this Ezime produce product in Omudike? No. Now you are talking that it's working, and then you are giving it another narrative. That is where that's how the research was supposed to flow. Clara, you are still raising your hand. Do you have anything to say?
Okay, no, sir. No.
Any other thing? One thing, let me just tell researchers here. Since 2003, I became a member of World Poultry Vet Association just to travel and see for myself. But in a comment like this, session like this, some research group can pick you up. I remember one in Egypt, another two in Denver, Colorado in 2003. When you make some the research world are coming to such conferences, and they're looking for people to partner with. And they'll be asking you, do you have anything for us to work with? And unfortunately, I'm a marketer. I'll tell them I don't have any. But the only thing in this area, I feel you can collaborate with some of the people in Nigeria. And they say, is there any other person? And they look around, there's no person. The world will move. If you present your abstract in all these world research organizations or world research bodies, even if they regiment your own to poster presentation, they will pay your transportation, pay your accommodation, because the world wants to learn. And you go there and make your presentation. You have put your name, and not to remain in one spot. You put your name in the map of the committee of researchers. And before you know, one research will come, they'll call you. If you finish this one, they'll call you. That's how people flow. And not as a lecturer and a researcher, you need to move around. You need to move. That's what we're talking about, breaking the walls. This anyway, please, please permit me to call for Florencio Fascina, maybe to add to what I'm just saying now. Professor Fascina, please. Okay. Hello.
Yeah. Hello.
Yes. Just polish. You know, I'm a crude person, so refine my statements.
No, what you said is very correct, and what I found out is that we actually are the one that shoot ourselves in the foot most of the time. We don't seek opportunities that are available globally. For example, when I started my career also, indeed, about my first 30 travels that I counted, I only pay half the travel cost for myself once. The remaining 29 and a half were all catered for by invited speaking. They pay you, pay your hotel, pay everything. And that's by one, you need to do good work. And good work doesn't mean perfect work. You don't need to be perfect before you begin to seek international collaborations. And such international collaboration also enhance you as a person. For example, if you can do your work alone and maybe publish it locally. If you publish it locally and it's a good work, it gives you a platform to move higher. And by the time you seek international collaboration, like we said, like maybe you apply to attend an international conference, they do have funds to support researchers from low-income countries. If you are selected and you go, then you begin to form partnership. And let's say your next paper or your next update on the work you are doing has some merit, you find international collaborator, they can say, okay, can we add value to this work by doing this aspect of your work for you? Even you yourself may know that those aspects are necessary, but maybe you don't have funds to cover it. For example, wherein you use your salary to maybe pay for page charges and things like that, or to do the bench work. Outside the country, you have many opportunities. For example, when I was doing my master's, I have about 5 grants running at the same time in South Africa. So I was able to even expand my research beyond what I initially planned to do. I had a PhD student from Nigeria who just finished last year. He wanted to go present his work in Botswana. The DITRA in US took up the funding. They paid for him, paid for his hotel, paid for everything. And these opportunities are almost always there. But in most cases, if you don't apply to maybe such conferences, for example, the next one is coming up in South Africa this September now, the World One Health Conference is coming up. We also have the one coming up in Australia now, which is the World Society for Preventive Vet Medicine and all those things. Is coming up in Australia. We also have the SVEPM, Society for Vet Epidemiology and Preventive Medicine, which always happen in Europe every year. These are opportunities. And once you have good work that have been submitted, you can always look for funding to support it. So the first thing is to seek and to submit, as Dr. Ebe has said, and then later begin to look for funds to meet such need. And I can assure you there's almost always fund. I know that the research institutions in Africa, especially in Nigeria, also need to improve. We are not there yet, but I'm telling you, there are still some effort being made. For example, the CARGS under Agric Research Institute in Nigeria is trying. We also have the ETF do fund some of these outside the opportunity. So we have opportunity both locally, which may not be many, and we have internationally, which are many that can cover some of these things. I'm not here to give another lecture. I enjoyed the
it's okay. We will bring you back, Prof. We'll bring you back when we are dealing with students, because we'll soon enter into the students' enclave. We want to deal with vets and young vets, emerging vets and coming up. Just like I said, you know, a lot of research, we need a lot of research. Look at me using anti-malarial plant to treat trypanosomes, and it worked. There are a lot of, you know, when people are telling all these native doctors, they will not tell you what they put in those concoctions. All I need is just, if I'm in research, take those concoctions to a lab. They'll tell me where the trees they are coming from or the plants they are coming from. Get it to an international lab, subject them to trials, phytoanalysis. There's no way biochemically they will not tell, taxonomically trace where those concoctions are coming from. So let's be loud and proud. So that is it. So Okayito, please, for driving you out of our way. It just like this thing just came up. Is Professor Okayito still with us? Yeah. Unmute yourself, Professor Okayito. You mute yourself. So can you round up? Yes. Are you listening with interest?
Well, are you hearing me?
Yes, we're hearing you, sir. Yes.
Okay. Well, to round up this discussion, you know, like I said much earlier on, CBPP is endemic. You know, we have what we call endemic stability. But all of us, the veterinarians, we must put our hands on deck, you know, hopefully with the government support to see how we can eradicate the disease. And I'm also calling for NVRI. You know, this liberalization of vaccines, you know, they should stop it. They should stop it because it's not helping our farmers.
Yeah. You muted yourself. Continue.
You know, he went and bought about 10 vials of PPR vaccine and administered to his, you know, to his sheep and goats. And honestly, all of them died. You know, so who bears, that kind of losses, So we should, stop it. If we are to, make our profession a notable one in the country, So that is it. And I also want to add that, we are always available, for questions, most of our students that are out there in the field, instead of shooting in the dark, not knowing what to do, they can call on us. We can put them right, So that is why we're here. Even though some of us will soon retire, but we are still active. We're not tired. Thank you very much.
Yeah, Dr. Akpan is saying we're linked where we can get all these international. The lecturers here with us. All these international opportunities. Is there any link where you can get all these international opportunities? The only thing is that, yes? You can talk.
No, I am not internationally connected. I used to be, but I'm sure Professor Kudi will be able to help if need be.
Professor Kudi and
he has just stepped out. He's not around.
Who? Yeah, okay. Professor Fashioner, please, can you?
Yes, thank you. You see, these opportunities, one, we have them around us. For example, somebody has just been mentioned now. I know Professor Kudi has a lot of linkages in Europe and elsewhere. So, one, we need to start by using local resources around us. Also, if you Google this thing, it's always there. For example, the World One Health Congress was disseminated on, I'm a member of the committee, so I know, was it disseminated? We use Facebook, we use LinkedIn, we use Twitter, we use all the different social media. The same thing, the conference coming up for epidemiologists and preventive vet medicine and health economists coming up in Australia. We disseminated it through different platforms, including even the non-traditional platforms, including in emails and things like that. So it's always there. If you use some of this social media, look out for these things. Social media had become a tool now that you should not use only for playing games, chatting with friends and all those things. Also, you look for opportunities there. For example, I have a student who was doing a work on salmonella from Nigeria, and then we were just Googling, searching for references for his work, and we saw a platform in the US that are interested. There is a specific platform for salmonella research, and he put some of his work there, and they invited him at a point in time. He went there to make a presentation. We also have, I can give you an example. We have a student who did his master's in ABU Zaria. While I was in Nigeria at one time, we met and we discussed, and he was saying, he would like to. So he was doing his work actually on phytomedicine in one of the labs in Zaria. And when I got back to South Africa, as of that time, we talked to one of the professors, and he came over to South Africa to do the lab component of his work. And I tell you, that thing gave him a PhD opportunity in King's College in London. He's back in London. I'm sure most of us on this platform know him, Dr. Moraina. This is how he moved to London. So if you have the capacity in you, which I know many Nigerians do, because if you go internationally, where indeed I've challenged myself in a country, and we went to the remote part of the country, and I beat myself that I will not say Nigerian here. The first person to greet me at the airport was a Nigerian. And I asked him, young man, what are you doing here? And he asked me, Egban, what are you also doing here? So our people are very innovative and very creative. And you should not localize yourself. You see, the definition of a researcher is somebody that is locally relevant, but internationally competitive. Nobody is going to give you a different platform that, okay, let's lower the standard for you because you are coming from Nigeria. Everybody wants you to do good work. And as long as you can do it and showcase your effort and also use the opportunity around you, don't just go to the Facebook and Twitter and LinkedIn to just chat and play. Also look for opportunities there. Sincerely, those will be my best example. And you talk to senior colleagues, a lot of our senior colleagues around you, you may think they are old and they may not know. They know a lot. But if you don't talk to them, they just keep it to themselves, or outsiders begin to benefit from them when you, the people inside, don't. Indeed, I went to some country recently And people were talking to me about Nigeria. These are white people talking to me about Nigeria. They say, "Oh, I did my postdoc in ABU. I used to work in MBRI. I was wondering that this is the same MBRI ABU Ibadan that we don't even appreciate ourselves." And these people were talking about those things in glowing terms. That I begin to feel proud of myself being a Nigerian and having worked in some of these institutions. So the opportunities are always there. We should just be on the lookout for them. Thank you.
Yeah, thank you. Clara, which area in veterinary medicine are you?
Okay, so I'm in ruminant medicine.
Look at it.
Ruminant.
You are in ruminant medicine. A lot of what is the new name for? Is it biotics or is it biotics? I think it's one. I'm finding it difficult on bovine medicine and bovine practices. A lot of anyway. Next week, I want you to be next week. We are dealing with dairy medicine and economics next week.
All right.
We'll soon send the link. So we will, but don't mix. You can see what you're gaining. And some of you are Mudike sleeping, and this is how people are flying. But that's okay. Emmanuel Elisha, I want to say something. You ask one question. Can you, on brucellosis, can you, before we call it a day? So and your continuous stay will guide you a lot. If it's linked, we can link you. If you in ruminant medicine, I know that there is an international association for ruminant medicine. Go and get it. Once you get it, you know when they are meeting, either every 2 years or 3 years. Because I'm in the one of Poultry Veterinary Association.
All right.
World Poultry Veterinary, World Veterinary Poultry Association. I'm a member.
Okay.
I've attended the one in Egypt, the one in Denver, Colorado, and the last one I attended in Edinburgh. In fact, the one in Edinburgh, one of ours, Boala, who is the vice president of MVMA, he had some good presentation, powerful. He came from South Africa and left to South Africa to complete his PhD. That's how people move. You don't move. $1 now is, I think, going to 2,000 naira. If you have $10,000, do you know you have 20 million almost?
It's true. It's
or
true.
15 million. So why are you? People are in the world making money, but you must. One thing about research, you cannot be a relax or dogmatic to be in research, because if they test you are not competent, you are not. You are not capable. They will drop you. But if you are competent and be calculating what you are going to do. So in this country now, we need ruminants. People eat them like mad, and food. You are in food animal practice, which even make it more important. Which makes it more important. Which makes you to be in a strategic area on the highway to success. Anyway, Emmanuel Elisha, you can say something.
Yes, a very good afternoon. It's just about noon. Thank you so much, sirs. Thank you, professors, my teachers, my mentors. This has been very much a refresher, and I've learned quite a lot too, listening on the call. My undergraduate work was on brucellosis screening, and following the talk from last time with Professor Fashina, I took it up as a personal challenge, sleepless nights, looking up opportunities in this area. Quite frankly, I have not been successful yet. I'm still on it. That is just a request on the side. But now on the CBPP issue, a lot of people pride that they can treat on the field. They pride that they have some wonder combinations that nobody knows about on the field, and this cannot be backed up.
No, what you are saying is a sweeping statement. And sweeping statements are not backed to research, but by research.
Correct.
And then research is the only thing that backs up research is objectivity and not subjectivity.
Correct.
So if you have anything to say or wind up, we don't discuss subjective issues. We discuss objective issues. Yes.
Correct. So that was why I asked about the test kit, something that can be used on the spot there and then. Then secondly, I mentioned the vaccine influx in terms of different sources.
We will bring some people on brucellosis. Don't worry. We'll bring people on. Today is CBPP. When it comes to
Yes, correct.
when it comes to brucellosis, we'll know how to tackle it. We know what to discuss.
Yes, sir.
Yeah. And then you discuss your anyway, Professor Okayito, you've rounded up so that I can round up. Professor Okayito.
Yeah, I'm listening.
Yes, I hope you're enjoying our mode of discussion
so,
now.
What do you want me to say?
Yeah.
You hope what?
No, I hope you're enjoying our discussion.
No, it's quite stimulating. You know, it's quite interesting. You know, I believe, you know, you're doing justice. You know, you're trying. You know, and I also believe that most of our younger colleagues are listening. They probably will learn one or two things, you know, from our discussion, you know, which will help them in their practice, you know. So that's just it. So I say kudos to you. Well done, more grease to your elbow. And I look forward to more presentation.
I dare you too. Please, our youth, this program we're having today is in the YouTube. I've sent the YouTube channel and I've published it here and there. I'm going to send it around as it's coming, be passing it around. But remember to subscribe to our YouTube channel. It gives us impetus and the algorithm.
Yeah, I will, no problem.
Yes, it gives us the algorithm to spread our tentacles. And then we'll move forward. Now, like I said, next week, we're going to deal with, Dr. Celestine Ayok will come and deal with.
Okay, with dairy.
With dairy practice and economics. Yeah, he's going into, you are afraid of going to the bush, but he enters the bush to pick milk.
No, he's my friend. We have worked together, you know, in the dairy farms. You know, he goes in as a dairy man, and I go in as a medicine man. You know.
Good, but this time around, he's in the bush in Nasarawa, Niger, and Plateau, picking up milk for the Nestle company in Lagos.
That's interesting.
That's interesting. He's going to tell us the model he's using to break into the bush. Remember, the narrative we hear is breaking the walls. There is no wall that is, if Berlin Wall can be broken, the iron the iron curtain in China was broken. I don't think there's any wall that cannot be broken, to be frank with you. So
that's true. That's true.
On this stretch, we don't talk about impossibility. We talk about moving the impossibility to difficulty and from difficulty to possibility. So on this stretch, sir?
Yes. No, I say sometimes you have to look at all the risks, you know. For instance, now I still have one of my staff, you know, in the kidnappers' den. They're asking for 30 million and nobody was ready to help, you know. So sometimes with these things happening around, we have to be very careful, you know, because some of us were just like an insurance, you know, to our family. You blow the insurance, many people will be affected, you know.
Prof, don't you know that if you die now, you go to heaven? Which one do you want to stay and suffer more?
No, not really. I'm not yet ready. It's not yet my time.
But
I still have a lot to contribute.
You want to go to heaven, you don't want to die.
No,
you are joining like people like us who don't want to go to heaven in quotes. Anyway, you know, if I'm the one, it's okay. You must laugh. That's why we are created. We are born to laugh. Thank you very much. Then we will discuss with him on next Saturday. He will tell us the model he's using to break into the walls of the bandits in the bush. And he's picking he's picking as much milk as he wants in the bush.
Yeah, he will.
Yes. He will come in to discuss it. And then he's an expert in dairy. Expert.
He is.
Trained in Barneveld. You know, there's this practical training institution in Holland where there's any area of whatever, any area of livestock. They will train you and retrain you. And he went there to do dairy and got distinction in dairy management in Barneveld, of all places. He will be here. We are looking from digging deeper to see people who have gone through some miles in this profession to deal to be able to to use their narratives and experience, that uncles on the experience, to see what much they can do to advise the beginners or those who are not gone some miles. Thank you. Yeah, on this stretch, I think, well, I am calling the meeting to a hold till next week. Thank you. Thank you very much. I'm trying to.
Thank you very much, also. I appreciate it. All right.
Thank you, sir.
Yes.
All right.
See you. Bye.
Bye, everybody.
Bye-bye.
Yes. Yeah. Bye, everybody.
Bye, sir. Thank you, sir.
Yes. Who is this? Who is Professor Hassan? Is this Zwaka? FB Hassan. Professor Okayito?
No, that is the wife. That's the wife. I'm just seeing her face.
My sister.
Are you my brother?
Yeah.